Hi, I'm Crystal Waters,
And I'm Michael Woolard.
and today we'll be talking about anesthesia for the elderly. We're going to cover pharmacological considerations, including a case report of an uncomplicated surgery in a 107-year-old patient. Okay, so this presentation will be broken down into two sections. In section 1, we will review a case report detailing the anesthesia-related implications that contributed to the successful repair of a hip fracture in a 107-year-old patient. We will then move on to section 2, where we will review the physiologic changes associated with the geriatric populations, including pharmacokinetics and pharmacodynamics. We will then end the presentation with a discussion about the materials covered. Let's get started. As we all know, living to 100 years is no longer a rarity. Advances and improvements in medical science have increased life expectancy, and perioperative surgery and anesthesia in the elderly patients has become an extremely important issue. People are getting older, and some of them still need surgery, but knowledge is power. In anesthesia, it's important to consider geriatric implications related to the medications we deliver to our patients. If we truly understand the implications of aging on the human body, we are able to deliver safe, effective anesthesia for the elderly population, and we are able to reduce their risk of perioperative complications. Now let's review a case report that shows a good example of this, detailing anesthetic management for a 107-year-old patient who underwent hip surgery free of perioperative complications. Section 1, Case Report. The case report we'll be reviewing today is titled Successful Anesthesia and Hip Surgery in a 107-year-old Patient. It was published in the American Journal of Case Reports in 2014. Okay, so let's dive into the details. The bio of this patient. She was a 107-year-old female with a BMI of 21, ASA score 2, presented to the emergency room with a right-sided hip fracture. She had no history of hypertension, hyperlipidemia, diabetes, cardiac arrhythmias, or prior complications with anesthesia in herself or in blood-related relatives. For her labs, significant labs included a hemoglobin of 8 and a hematocrit of 25.7%, and her lab work was otherwise unremarkable. Due to the anemia, she was given 2 units of PRBCs prior to surgery, and a repeat CBC showed an increase in hemoglobin to 12.4 and an increase in hematocrit to 35.2. Surgery was then planned for 5 days later. Continuing our case report review, we move on to the day of surgery and pre-op. NPO status. The patient was NPO since midnight, then given a single 200 ml carbohydrate beverage orally 2 hours pre-op. A balanced anesthetic plan was chosen that included a psoas compartment block, a spinal, and light sedation. For the lumbar plexus block, 20 ml of 0.5% bupivacaine and 20 ml of 2% lidocaine with epi was used. The spinal was done in the operating room after 5 milligrams of ketamine and 0.5 milligrams of midazolam was given for pre-spinal sedation. Additionally, the patient was preloaded with 4 ml per kg of crystalloids and 500 ml of 6% Voluben. Note here the small sedation dosages used. It's very important that sedation administration be appropriate for the patient's characteristics, as well as to be reliable and effective. In elderly patients especially, there's an increased sedative response to centrally effective agents such as midazolam and propofol, which is why in this case study, only 5 milligrams of ketamine and 0.5 milligrams of midazolam was used. Moving on to intraoperative anesthesia management. In this case, the only sedation that was required was the pre-spinal medications, 5 milligrams of ketamine and 0.5 milligrams of midazolam. Thanks to the regional and spinal coverage, that's all that was needed. And success! The surgical procedure lasted 60 minutes without hypotension, bradycardia, or decreased oxygen saturation. Case report review continued. Post-op management. PACU. For analgesia, the patient was given 20 milligrams of tanoxicam and 3 grams of dipyrone IV. She was also given 200 ml of IV fluids. So neither of these drugs were familiar to me, so I looked them up, and this is what I found. They are both available in the UK, not in the US. Tanoxicam is an NSAID, and dipyrone was actually at one point the most widely used pyrazolone derivative, a COX-2 inhibitor, but was banned in the US and much of Western Europe when found to cause serious or fatal blood damage via agranulocytosis. The patient was then transferred to the ICU for 24 hours observation due to her increased risk associated with her advanced age. At that point, IV fluids were withdrawn and oral feeding was resumed 6 hours post-op.
Now we're going to move on to section 2. We're going to review the physiological changes associated with aging, and we're going to do an overview of the geriatric pharmacokinetics, which is what the body does to the drugs, and the geriatric pharmacodynamics, which is what the drug does to the body. As anesthesia providers, it is important for us to understand the perioperative risk and complications associated with aging. According to Morgan and McHale, by 2040, persons aged 65 and older are expected to compromise 24% of the population and account for 50% of the healthcare expenditures, many of which will require surgery. It is imperative to have an understanding of the normal physiology, anatomy, and a response to pharmacological agents that accompany aging. It is important to distinguish between changes that normally accompany aging versus the pathophysiology of diseases that are common in the geriatric population. Let's discuss some normal physiological changes in the elderly. Expected cardiovascular changes. You will have a decreased arterial elasticity, which will create an elevated afterload, elevated systolic blood pressure, and left ventricular hypertrophy. They will also have a decreased adrenergic activity, which will cause a decreased resting heart rate, a decreased maximal heart rate, and decreased baroreceptor reflex. Expected respiratory changes include decreased pulmonary elasticity, which will cause decreased alveolar surface area, increased residual volume, increased closing capacity, ventilation perfusion mismatching, decreased arterial oxygen tension. They will also have increased chest wall rigidity, decreased muscle strength, which will cause decreased cough, and decreased maximal breathing capacity. They will also have a blunted response to hypercapnia and hypoxia. Expected renal changes. They will have a decreased renal blood flow, which will substantiate a decreased renal plasma flow and decreased glomerular filtration rate. They will have decreased renal mass, decreased tubular function, which will have an impaired sodium handling, decreased concentrating ability, impaired fluid handling, and decreased drug excretion. They will also have decreased renal aldosterone responsiveness and impaired potassium excretion. Now let's talk about body composition changes in the elderly and the anesthesia implications. Increased body fat creates an increased reservoir for lipophilic drugs. In other words, it increases the volume of distribution of lipid-soluble drugs. This extends their elimination time, as occurs with diazepam. Its elimination half-life is increased significantly in the elderly. Although this prolonged half-life might not be important after a single dose of diazepam, it would have more significant impact with repeated dosing. They also have decreased total body water, which creates a decreased volume of distribution, creating higher circulating concentrations. Therefore, hydrophilic drugs have a smaller volume of distribution and, for a given dose, a higher plasma concentration. This will generate a greater pharmacological effect. For example, morphine has a volume of distribution in the elderly that is only half of that in younger adults. They also have a decreased protective reflexes, such as decreased muscle tone, which then can create a higher aspiration risk. They also have decreased ability to retain body temperature due to decreased basal metabolic rate and muscle tissue. This highlights the importance of maintaining normothermia in the perioperative setting. Now onto pharmacokinetics, which is what the body does to the drug in the elderly. You have increased drug elimination half-time, which causes a vulnerability to cumulative effect with repeated dosing. We have a decreased renal clearance. As humans age, kidney function declines in part because of advancing glomerular sclerosis, leading to a 25 to 50% reduction in GFR. We also have decreased hepatic clearance. Because hepatic blood flow slowly decreases, and by the age of 65, there is up to a 40% decrease in hepatic blood flow. We also have an increased volume of distribution from increased total body fat, as we previously mentioned. Drug disposition and excretion are determined by body composition, adequacy of hepatic and renal function, decreased albumin production, as well as decreased plasma cholinesterase production in elderly men. Although we should note this doesn't significantly affect succinylcholine dosing or duration of action. Pharmacokinetic effects of anesthetic agents result from the changes in the quality and quantity of body tissues with aging. Pharmacodynamics, or what the drug does to the body, has not been as extensively studied in the geriatric population as pharmacokinetics, but this is what we know. Sensitivity to drugs may increase or decrease with age. Older patients seem to be more sensitive to benzodiazepines even when pharmacokinetic differences are taken into consideration. This is postulated to be due to age-dependent changes in GABA receptors in number and in subunit composition. As is well known, the MAC requirements are also reduced in the elderly for inhaled anesthetics. Alterations in ion channels, synaptic activity, and receptor sensitivity is probably responsible. There may also be less sensitive to drugs used in the perioperative period, like beta-adrenergic agonists and antagonists, such as isoproterenol and propranolol. Decreased receptor number and/or affinity are likely, along with alterations in cellular response. According to Morgan and McKell, as a whole, pharmacodynamics is most often the same in the geriatric population as in the non-geriatric adult, just changes in dosage requirements. For this reason, anesthetic plans should include careful dosing consideration for each individual drug chosen.
To piggyback on all the important geriatric changes in pharmacodynamics and pharmacokinetics Michael mentioned, we now apply those to our selection of drugs and techniques in anesthesia. Our inhaled agents are known myocardial depressants, so we must exercise extreme caution in CHF and those with low cardiac output. Furthermore, those with decreased cardiac output and delayed clearance of drugs, we will see delayed onset and prolonged effects that will create a significant risk of overdose in the geriatric population. As previously mentioned, most often in the elderly, there are decreased anesthetic requirements. We see a 20 to 40% dosage reduction in the following drugs: etomidate, barbiturates, propofol, narcotics, and benzodiazepines. Lastly, in patients with hepatic or renal impairment, and when appropriate, we should choose drugs that are less dependent on hepatic or renal metabolism and elimination, like remifentanil and cisatracurium.
And now for the discussion. Let's tie it all back together. Like we said in the beginning, although people are getting older, many are still going to require surgery, and age alone is not a contraindication for surgery.
But thankfully, knowledge is power. In anesthesia, it's important to carefully consider geriatric implications related to the medications we deliver to our patients.
The beauty of it is, if we truly understand the implications of aging on the human body, we are able to deliver safe, effective anesthesia for the elderly population and are able to reduce their risk of perioperative complications.
Hope you enjoyed!